This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Brain and Behavior, published in 2026. It's a systematic review and meta-analysis titled Early versus Delayed Cranioplasty After Decompressive Craniectomy.
This is a topic that hits home for anyone taking trauma call or managing stroke patients. We know decompressive craniectomy, or DC, is a life-saving measure for malignant intracranial hypertension, whether it's from TBI, ischemic stroke, or ICH. It restores cerebral perfusion by giving the brain room to breathe, so to speak. But as we all know, once the acute phase is over, we're left with a significant cranial defect.
Exactly. And that's where the syndrome of the trephined, or the need for cranioplasty, comes in. We aren't just doing it for cosmetics. We're looking to protect the brain and ideally improve cerebrospinal fluid dynamics and cerebral blood flow to promote neurological recovery. But the million-dollar question has always been, when do we put the bone back?
Right. And this paper, led by Mohammed Taha and colleagues, really dives into that debate. They defined early cranioplasty as occurring within 2 to 3 months post-DC and delayed as anything after 3 to 6 months. Elara, walk us through their methodology before we get into the meat of the results.
Of course. The team conducted an electronic search across PubMed, Embase, and Cochrane. They used the Rayon software for independent screening and utilized the Newcastle-Otala scale, or NOS, for quality assessment. They focused on a few key metrics: overall complications, postoperative infection, operative time, intraoperative blood loss, and functional outcomes like the Glasgow Outcome Scale and MMSE scores.
It's a robust approach. Let's start with the surgical efficiency side of things, because the results there were quite striking. For the residents listening, pay attention to the operative time.
Definitely. The meta-analysis found that early cranioplasty resulted in a significantly shorter operative duration. We're talking about a mean difference of minus 26.76 minutes with a p-value of 0.0003.
Nearly half an hour saved. And they also saw a reduction in intraoperative blood loss, didn't they?
They did. The mean difference was minus 21.53 units of blood loss, which was also statistically significant at p equals 0.01. The authors attribute this to the technical advantages of operating earlier, specifically having to deal with less scar tissue formation and fewer adhesions between the dura and the scalp flap.
That makes perfect sense clinically. If you wait 6 months, that plane between the skin flap and the underlying dural substitute or brain can become incredibly fibrotic. It's the difference between a clean dissection and a tedious centimeter by centimeter struggle. However, neurosurgery is never just about speed. We have to look at the safety profile. What did the meta-analysis show regarding complications?
This is where the results get a bit more nuanced. When looking at overall complications, the early cranioplasty group actually had a higher risk, with a relative risk of 1.43. However, the 95% confidence interval ranged from 0.81 to 2.53, and the p-value was 0.22. So while there was a trend toward more complications in the early group, it did not reach statistical significance.
And what about the big one, infection? That's usually the primary reason surgeons cite for delaying the procedure.
It was a similar story. For postoperative infection, the early group had a relative risk of 1.36, but again, it was non-significant with a p-value of 0.65. The supporters of delayed cranioplasty, as the paper mentions, argue that giving the brain and surrounding tissues more time to recover should lower the risk of wound healing issues and infection. This data shows a slight lean in that direction, but it's not a definitive slam dunk for delay.
It's interesting. We're seeing a trade-off. Early surgery is technically easier and faster, but there might be a higher, albeit not statistically proven here, risk of complications. Now, let's talk about why we do this in the first place, the patient's recovery. What did the study find regarding neurological outcomes?
This was perhaps the most surprising part of the review. Often, we hear that early cranioplasty helps neurological recovery because it normalizes atmospheric pressure and improves CSF flow sooner. But in this meta-analysis, the results were mixed. For the Glasgow Outcome Scale, or GOS, there was no significant difference between the two groups. And when they looked at the Mini Mental State Examination, or MMSE scores, they actually favored the delayed cranioplasty group.
That is a bit counterintuitive based on some of the older cohort studies we've read. The paper notes that previous work, like the study by Malcolm et al., suggested early cranioplasty was associated with improved motor outcomes, but this 2026 emphasis seems to pull back on that enthusiasm a bit.
It does. The authors highlight that because of these mixed results, we're still looking for that perfect balance between surgical safety and functional recovery. They were very transparent about the heterogeneity in the data. For example, the I-squared for operative time was 80%, which is quite high.
That heterogeneity usually stems from the diversity in patient demographics, the initial reason for the craniectomy, TBI versus stroke, and how each center defines early. It's hard to compare a 6-week cranioplasty to a 12-week one if they're both labeled early.
Exactly. And the authors conclude that while early cranioplasty has clear technical benefits, faster, less blood loss, it doesn't necessarily translate to a safer profile or better cognitive outcomes in this specific data set.
So for the residents and attendings listening, how do we apply this? If I have a patient who is 8 weeks out from a TBI, their brain is no longer swollen and they're starting rehab, does this paper change my mind?
It suggests we should be cautious. While you might save time in the OR, the risk of a complication might be higher. Even if the p-value didn't hit 0.05 in this meta-analysis, a relative risk of 1.43 for overall complications is something to keep in mind during the consent process. The authors ultimately call for a prospective, multi-center, randomized controlled trial with very specific outcome measures to settle the debate.
I agree. The technical ease of early surgery is a real benefit for the surgeon, but our priority is the long-term functional status of the patient. If the MMSE scores are actually better in the delayed group, we need to understand why. Is it just that the patients who were stable enough to wait longer were healthier to begin with? Or is there a physiological reason?
That's the limitation of systematic reviews. We're at the mercy of the original study's designs. But as it stands, this paper provides a great bird's-eye view of where the literature is in 2026.
To wrap up, what are the 3 key takeaways for our listeners?
First, early cranioplasty within 2 to 3 months significantly reduces operative time and intraoperative blood loss because of fewer adhesions. Second, there is a non-significant trend toward higher overall complications and infections in the early group. And third, functional outcomes like the MMSE did not favor early intervention. In fact, they showed a preference for the delayed approach.
Excellent summary. It's a reminder that in neurosurgery, faster isn't always better for the patient's brain, even if it's better for our schedules.
Absolutely.
Well, that's all the time we have for today. Thank you for joining us on the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Alara. We'll link the full Taha et al. Paper in the show notes. See you in the next episode.